Okay, so our next speaker is Alexandra Witt, who is a graduate student in the lab of Dr. Edward Prysdale. She'll speak to us today about a mutated clotting factor 10 as an adjunct for thrombolytic therapy. Alexandra, thank you.
Excellent. Thanks, Hugh. And the introduction is done, so I'll get right into it. Tell you about the big problem, which is heart attack and stroke. As many of us know, these are the leading causes of death worldwide, and they're often caused by a blood clot that blocks the flow of blood. Now, they're currently being treated by this little golden enzyme here, TPA, which is tissue plasminogen activator, and sold under a couple of drug names. Some of the doctors might recognize alteplase. If you use mice, you might recognize tenecteplase. And these have been excellent at reperfusing these patients, but unfortunately, a very large dose is required, which will lead to systemic bleeding, including cerebral hemorrhage in as many as 7% of patients. So our goal has been to fix that. And so to look back at why we use TPA, I bring you to fibrinolysis, which is the clot breakdown process. And so in red here, we have the fibrin, which forms the meshwork of a clot and will block the flow of blood. And that will bring together the TPA and plasminogen. TPA will cleave plasminogen into its active form plasmin, and with a small amount of plasmin at the site of the clot, will start priming the fibrin, so cleaving it a little bit and getting it ready for the big breakdown. And eventually, when you have that large amount of plasmin, you can break down the clot entirely. Now, one of the other reasons I've broken this down into fast and slow is to include an adjunct, which is factor 10. Now, factor 10, normally part of the clotting cascade, can be cleaved by that preliminary amount of plasmin into factor 10 beta. And factor 10 beta happens to be a wonderful auxiliary cofactor to the fibrinolytic process by bringing together more TPA and more plasminogen to help generate plasmin and break down the clot. And so for this reason, you can imagine giving a patient more TPA generates more plasmin and breaks down the clot. And we are going to take advantage of factor 10 to hopefully reduce or completely replace the TPA dose required. We have generated something we like to call RFXIC. This is little r stands for recombinant or lab made, and little I and C stand for the two mutations that we've made to our factor 10. The first one is little I for inactivation. So in the catalytic triad of our beautiful serine protease here, we can generate 10A, which forms a clot. And that would be a horrible thing to give to patients who want to break down clots. So we have inactivated our factor 10 by switching a serine out for an alanine and calling that our little I mutation. The next mutation is little c or cleavage resistant. And so because that initial amount of plasmin can generate factor 10 beta, which we do want, we want to make sure we can have that cleavage happen. But we don't want a secondary cleavage to occur, which generates a non-fibrinolytic form of factor 10. So we have mutated one of our lysines to a glutamine to inhibit that cleavage. And now to see that in action, in vitro at first, what we're looking at here over time is generation of plasmin, so that TPA and plasminogen alone can only generate so much plasmin at this time. But if you add in my double mutant RFXIC, we can generate 5 to 10 times more plasmin in the same amount of time. Now, does this actually work to break down a clot? We can test that in vitro as well. This, once again, over time, our x-axis is now clot amount. So what we're measuring here is the amount of clot that is formed at time 0, where we watch it completely occlude a vessel, or in our case, a little microwell plate, and then we can watch for clot breakdown. Now in black at the top, a negative control, this clot's not being broken down at all. But when we add a little bit amount of TPA, we can start to see clot breakdown at a very reasonable speed. We're looking over a couple of days right now, or hours. But if we add our factor 10, we have a wonderful adjunct effect where we can break down this clot even faster. And so we know that this is time to put it into mice. And so the very exciting data that I have today is looking at our factor 10 as an adjunct therapy in mice. This is a carotid model of thrombosis where we expose the carotid artery of a mouse and hook a Doppler ultrasound underneath it. This will allow us to record blood flow, which we can see stop when we cause injury with ferric chloride. So this completely occludes the blood vessel and blood flow returns to 0. Then we give the drug of choice, which as you can see along the bottom of this table here goes from no drug at all to different combinations of tenecteplase, that TPA variant, and my double mutant factor 10. And we wait to see time to reperfusion, which is what this table is showing us. So if the mice are given no drugs, 0, 0, you can see they're not going to reperfuse past our experimental endpoint. And then as we give them a full dose of tenecteplase, 20 micrograms per gram, we have a wonderful reperfusion at about 16 minutes. If we half that dose, it becomes subtherapeutic. So a 10 microgram per gram dose of this tenecteplase is subtherapeutic. And this, pardon me, there should be a 2 here, just a dose of factor 10 on its own is also ineffective. This is subtherapeutic. But if we combine both of those doses together, we can see reperfusion at about 16 minutes, very similar to that of a full dose of tenecteplase. And we have titrated this down to see if we can reduce the tenecteplase, but so far these reperfusion times are a little slow for our liking. So we've turned instead to this new data, hot off the press this Monday, where we have increased the dose of the factor 10 in comparison with a nice low dose of tenecteplase, and again seeing reperfusion around 15 minutes, which is excellent work for us. So this has told us this is probably going to be an effective dose as an adjunct for TPA. But is it safe? And I'll remind you, the whole reason we're doing this is because TPA causes systemic bleeding in many patients. And so what we're doing here is looking at biomarkers of this systemic bleeding. So here we have fibrinogen fragments in a blot up top and plasmin fragments in the bottom. And so each of these lanes represent a mouse who has received here 0 drugs, the full dose of tenecteplase, or that half 10 and 2 dose of the adjunct drugs. And up top, I'll bring you here, you can see that if the mice receive no drug, they have no lytic fibrinogen fragments. But a full dose of tenecteplase gives a full array of all of these bands here, which represent systemic bleeding, including potential cerebral hemorrhage in these mice. And by decreasing that dose of tenecteplase down to 10 micrograms per gram, we're able to also decrease these markers of systemic bleeding. The same goes at the bottom. For plasmin, we see a lot of plasmin generation when tenecteplase is given, and that is systemic, again, not just at the site of our clot. And thankfully, we're able to decrease that here. So our next steps will be to try a couple more titrations, see if we can get these bands as low as possible with an effective dose, and hopefully change the game in terms of thrombolytic therapy. So with that, I will take any questions.
Alexandra, are you able to hear me?
Yes.
It's beautiful work. It's very important. I would recommend you may test different animal models for the hemostasis. And particularly, if you could, to test in the stroke model to see what happens. Because so that's hemostatic situation may slightly different from the brain as compared with other tissues.
Yes, thank you. That's an excellent suggestion. Yes.
I agree. That's very beautiful work. I don't understand this last thing here. Mm-hmm. If the way that the R factor 10 IC is working is by increasing the efficacy of the plasmin, then shouldn't you be generating kind of the same lytic product?
Our hypothesis is that we're only generating that lytic product at the site of the clot compared to TPA or tenecteplase, which is activating these systems systemically. So what we're doing is a full blood draw from the mouse after the experiment and seeing the plasmin that's generated everywhere in the body. But we have not yet been able to determine for sure that the plasmin is just being generated at the site of the clot. But our hypothesis is that the factor 10 is able to localize much better than the TPA.
Well, that's a good explanation. So the recombinant actually binds only in the setting of bound to fibrin?
Yes, so we are seeing fibrin and fibrinogen binding as well as binding to the anionic phospholipids that are exposed at the site of the clot.
Okay. Thank you.
You're welcome. Hi.
Hi, very nice talk. One of the problems with TPA is it only works within a couple of hours of formation of a clot. I wonder if you tested your this new clot buster in clot that forms more than 5 hours or a few days old.
We haven't been able to do that in our mouse models yet. We do have a couple models in the lab in vitro where we could test a mature clot and then that clot busting, but as far as I know, we'd be sticking to that 4-hour time frame until someone else later on in clinical trials is able to change that.
Thank you.
Thank you. And I will be at poster 4 if anyone has any more questions. Thanks.